Hi, my name is Elena Shepard. I hold a CNA and an LNA in the state of Arizona for nursing. I have been an LNA for going on 7 years now. I have done everything from bariatrics to home health care to I currently work BMT oncology, which is bone marrow transplants. We deal with blood cancers and stem cell transplants. And I wanted to give you a little bit of background on why I wrote the paper that I did. A few weeks ago, I was at work, and I absolutely love my job. I think the hardest thing about my job is when people get put on hospice, and people die. And I think the most rewarding thing in my job is being able to be there when people get put on hospice. And I know that sounds like a weird part of the job because we want people to get better. But I think having a hand in what is the hardest transition for a family to go through is a beautiful thing. And so I wanted to give you the context for why I wrote this essay. I was taking care of a patient who was young. She was healthy before she got her cancer. She was a mom and a wife, and she had a 12-year-old son and was funny and this amazing woman. And then she got her cancer and she got her transplant, and then she didn't do well. And we sent her to the ICU, and she came back, and she had been in the hospital for couple months at this point. It's a couple years after having cancer. She just stopped talking. And, I was in there I had a stretch of days with her. And so I was in there trying to ask her what I could do for her and trying to take care of her and trying to offer help. And she just didn't want any help. She kept saying she wanted to be left alone. When she would talk, she would just look at you and turn the other way and roll over, and that was your cue to leave. And then when she would talk, she would say things like, "I just want it to be over. I'm ready to go. Let me go." And, people had brushed her off until finally it got to a point where we couldn't ignore it anymore. And so we had called the doctor and just said, "Hey, will you come put eyes on her?" And he walks in. And I was in the middle of checking vitals, so I was staying to finish up my task and then get a walk out. And he looked at her, and I will never, ever forget this. He looked at her, he pulled up a chair, he sat next to her, and he looked her in the eyes and said, "I think instead of prolonging your life, we're prolonging your suffering. And I think it's time to have a discussion about that." And then he broke into the conversation about the comments that she had made. And there's two types of conversations for that. There is, "I am frustrated and I am venting." And the other conversation is, "I am done." Specifically when you're fighting a battle that you're likely going to lose, at some point you have to decide what loss is. And so, we had an ethics consult for her. They had a goals of care conversation. They made a different plan. They put all this information together, and I was fortunate enough to see it kind of come to fruition. And then I was the one that was helping her get dressed to go home on hospice, so that she could die in her own bed. That's all she wanted, was to go home and die in her own bed. But even when she was leaving, I said, "Okay, well, I'm really sorry. I have these hospital-issued scrubs or this gown and this pajamas for you." And she wouldn't do it, and she started crying. And, I sat down and I talked to her, and she was like, "Nobody understands that I'm dying, and I want to die with dignity, and I want to die my own way." She goes, "I want my husband to bring me my clothes. I want to go home in my clothes. I want to be at home on my couch when my son comes home from school. I want to see him. I want to be a human being again, and I want to die with dignity." And so it sent me into this spiral of looking into like, how do we preserve people's dignity in the end of their lives? And that's what had sparked this whole paper, is just, how do we give people their dignity while they're dying, while preserving the sanctity of living at the same time? And so I did a lot of research. I did research on, how effective is CPR really? Like, what damage are we doing? How effective is intubating people? How effective is all these like end of life goals? Because there was more things that we could have done for this woman, and we could have bought her 8 more months. But if we bought her 8 more months, she would have never seen her son again because he was too little. She would have lost her ability to speak or function. She would have had tubes galore. She would have been in and out of the ICU more often than not. She would have racked up hundreds of thousands more dollars of debt for her husband. She would have never, if they didn't stop giving her quote unquote treatment or options, she would have never left the hospital, and that wasn't living to her. And so I think that it's an interesting thing that in America, we equate fighting the fight with living, and sometimes fighting the fight is knowing when to give up, and how we can help people in that transition. So that is what I get to talk to Andra about a little bit. She works in that hospital setting. She was on that case with me specifically, and we didn't break into that case in the podcast here. We talk more about generalities and like how we can help people as a systemic hospital systems, and what navigating that would look like, and then her opinions on things like advanced directives and stuff like that. Hey, Andra, how's it going?
Good. How are you?
I'm doing well. So do you want to give me the spiel on your, how long have you been doing oncology?
Probably about 5 years now.
Nice. What do you like most about it?
At first I never thought I was gonna go into oncology, but it was like my first job out of nursing school. And now I kind of just like the science and research behind it. It's like a sad department to work in, but it's also very fulfilling at the same time.
Very nice. Well, I'll jump right into the meat of it. Um,
Okay.
Obviously, I'm going to just give everyone the background. You do oncology, but you also do BMT oncology, which means all of the stem cell transplants. And
Correct.
do we do anything that's not stem cell transplants?
We do a lot of research, like the bispecific, more like that's not FDA approved yet. So like Mayo, I would say like 50% of our patients are bispecifics, like they get injections or certain infusions for like research for cancer.
Do you think that in our field specifically, that patients and family members get quality education and are aware of like what the reality of treatment looks like?
So I know in the beginning, before the patients like accept the going through the transplant process, our providers, the patient care coordinators, transplant coordinators go through everything with these patients. They talk about what to expect before, what to expect during, what to expect after, and months and years after. But of course, if you ask the patients when they're going through it, if they have any adverse reactions, negative side effects, the patients always tell us, I was never told this in the beginning. If I knew it was going to be like this, I wouldn't have done that. But I think before they're going through the process, it's a lot of information to retain at once. So I feel like some they don't really understand.
Do you think that
I know for I know for a fact, like some of our nurses that are part of the coordinators to train, they go through all the education. I think they are, but if you'd ask the patients, they'll probably give you a different answer.
well, I'm sure it's hard to be like, hey, like this is your for a lot of these people, like, this is their last kind of
This is
option.
their last hope. Yeah,
So if someone's
exactly.
like, "Hey, here's the side effects of your last hope," you're like, "Okay, well, cool. The side effects are die."
Right. I mean, like, we have so many patients right now who they don't understand how bad the mucositis can get, like in their throats and mouths, and they think they'd rather die than be going through this process. So I feel like they don't understand how bad it can get. We do because we've seen it.
Mhm.
But I mean, these patients are scared, like this is their last hope. And I mean, I kind of understand how they would feel that way too.
Do you think that other patients that you've seen, like in a hospital setting, not in oncology, because we do also get a lot of
Internal medicine.
internal medicine, do
Yeah.
you think those patients get enough education at what, like, their quality of life looks like post either stroke or TBI or things like that?
From a personal experience, I have not seen that. I feel like our hematology and oncology doctors are such a rare breed of people, and
Yeah.
they do so much education with these patients and like hands-on care. Versus internal medicine, it always seems like, okay, you're being discharged, go see your outside healthcare provider, and then they're done with them.
Yeah. I would agree with that. Do you think what would you say the hardest part about your job is then?
I feel like the hardest part is seeing patients that are younger than you, and you don't really understand like why them, even if they've lived like such healthy lifestyles. And when you're taking care of patients that are younger than you, it feels very like almost not inhumane, but just, I mean, it's so hard to do because you're trying patients that are 23, 24 with cancer. I'm like, when I was 23 or 24, like I was just like in school, just trying to get through school, thinking I was going to die because I failed an exam. But it's like these people have not lived their lives yet. So I would say the hardest part is taking care of people that are younger than you because we just don't know what they're going through at that age.
That's that's very fair. Um, do you think that we keep patients alive longer than we should? Or are you of the camp that, like, as long as their heart is beating, like, we're doing the right thing?
I mean, I feel like in certain circumstances, depending on the age, like we'll have patients who we know they're dying, but when they have that full code status on them, our providers will take every measure, every test, every procedure to try to keep them alive. But then when we have patients that are like DNR, I feel like the providers don't try to do everything they can because of their code status. But definitely feel like there are procedures or tests that they do on certain patients that is just going to cause like more pain and misery in the end.
So do you think that people that are DNRs don't get the same quality healthcare that people that are full code get?
I kind of seen that from a personal experience. Like if they're DNR, DNI, I feel like the providers see that as that, even though it's just like, do not resuscitate, do not intubate. I think some providers, I mean, it's some, not all, but have seen that not as like a way to give up. But if you're 93 and you're DNR, DNI, and you have pneumonia or you're not eating, like, do you place like an NG tube? Do you place a peg tube to keep them alive? Or since they're DNR, DNI, is that their way of saying, hey, like, let me go my own way? Like, don't do all of these tests and procedures. That's why a lot of providers will ask the patients, like, or their family members, do you want an NG tube? Do you want, a peg tube, etc.? But I do kind of think their care changes based on their code status.
Do you think that's necessarily a bad thing? Or is it just
I
a thing?
mean, that's a good question. I think there just needs to be more education with the patients about code status. And that's why we always try to emphasize, like, do you have a living will? Like, what types of procedures and tests do you want to do to help kind of like prolong your life? Um, yeah, no, that's a good question though.
I have one more question for you.
Yeah.
At what point do you think that it's unethical to keep someone alive? And then when we reach that point, what do you do as a nurse?
I mean, I think it's would be considered unethical to keep someone alive against their wishes, or like when medical interventions prolongs like their pain, their suffering. Like say someone's in a coma, and they won't get that meaningful life ever again. If you're just kind of prolonging the pain and suffering, like, is that human dignity? Not really. But I know that like each hospital, like at Mayo, they have the ethics committee board. So I mean, there's been times where I've brought on ethics because, you know, the patient has dementia or the patient can't talk, and the family members want to do all these tests and procedures to kind of prolong their life. And that's when we bring the ethics committee on board to kind of talk to them like, hey, it's up to your, you know, that your family member. It's not up to you.
Yeah.
And then, I mean, like the ethical guidelines is like, you know, respecting patient autonomy, preventing suffering, acknowledging when the burden of treatment like outweighs any benefit for the patient.
Do you think that patients are getting enough education about like, hey, the burden of treatment is going to prolong your loved one's suffering rather than being helpful?
I think so, but when you have someone in your family that is going through that, I don't think they fully understand what the doctors are saying. Like, I mean, say your child, your mom, your dad, your sibling is there, you know, about to die and then they can't talk. Of course, the family, I feel like they're so focused on keeping that person alive that they don't even focus on what like the ethics committee or provider is saying in the end.
Do you think that there's a way that we could be rectifying that? Or not really? That's just the nature of the beast.
I feel like that's just the nature of the beast. That's just like an average human where you just want to try to keep your loved one alive as long as they can. And is that selfish? I don't know. I mean, it kind of depends on the person. But I mean, from seeing how like people, how members, I mean, handle it great. Like we'll have some patients who are intubated and all this, and they're like, this is not what they want. They always said from the beginning, they do not want to be going through suffering. Like, let them die in peace. So that's when, you know, in the ICU, they'll extubate them. But then you have other family members, and you probably remember some of these patients where the families do anything to keep them alive. And like we have that one patient who's like literally 30 kilograms and she's been suffering for what, 8 months?
Yeah.
So yeah.
Okay, well, I appreciate your insight. I will let you go because I promised you a 5-minute interview and I feel like I have exceeded that.
You're fine.
So thank you for your input and I appreciate you.
I also interviewed my mom for a different, deeply personal reason. When I was 9 months pregnant, I was 9 months pregnant with a nephrostomy tube. I had a really bad kidney infection, so I wasn't allowed to be there in the hospital. And also, I was dealing with a few other big life crises. So I asked her a lot of questions in this. You're like, why weren't you more involved? It's because I was dealing with other things, and I was told I was not allowed to see him. But my father at this time had a massive stroke. He had a hemorrhagic stroke that they intubated him immediately, put him on life support. He survived. The night that happened, I think they coded him 3 times. They put in a stent. They woke him up. He was able to be pulled off the ventilator. He did talk for a little bit, but he never cognitively was there again. And he was hemi-paralyzed, which he had made very, very, very clear in all his wishes to all of his children. Should anything ever happen to him, his dad's thing was, should anything ever happen to me and I can't wipe my own butt, you pull the plug. He made that very apparent to all of us kids. And him and I had deep, in-depth conversations after the death of his brother about like what he wanted to, do in all of these situations, especially as I was in the medical field and going through these things. I would ask him like, would you consent to this? Like, do you want them to do this? And we had lots of conversations. So I had a really good idea of what he wanted. But unfortunately, his wife did not show up for him and didn't sign any of the paperwork, didn't make him a DNR, though I begged her to make him a DNR, a DNI, after they had resuscitated him the first time. I think that they probably resuscitated him 6 or 7 times. And he should not have been. He was not with it. He was stuck in a body that he did not want to be in. But his wife was not capable of making that decision, but legally responsible for doing it. And so instead of making a decision, she just abandoned him. He then became a ward of the state, and the state got to decide what to do in that case, despite the fact that his ex-wife, my mother, knew exactly what he wanted. All 5 of his children agreed on what he wanted, and his mother agreed on what he wanted. All 7 of us involved knew exactly what he wanted. He was very clear in his entire life. This is what I want. This is what I want. This is what I want. But because he died without it in writing, when he became a ward of the state, the state said, here, and just stuck him in a facility in a room and didn't do anything else until he just eventually died. And so that's what the conversation with my mother focuses on, is more how would this life have been different if we didn't do everything? And so I think that it's an interesting conversation. And I think that it's hard for people to imagine and navigate this situation when you are not somebody that works in the healthcare field. I see people die every day. It's not that it's not sad to me anymore. I just have a very big understanding of like sometimes death is the best thing that can happen in this situation, which sounds unfair and it sounds hard to say. And I would never say it to a loved one that is actively grieving. But there is something to be said about the fact that like you do have to realize out of all of the scenarios that could happen, death is not the worst case scenario. And I think that in America, sometimes we think it is. We think that that's the end, that's the loss, that's the whatever. But dying before your dignity is stripped from you is sometimes not a bad thing. And so I just would implore you to open your mind while we're having this discussion and this conversation to kind of understand that like the idea that keeping people alive is the best thing is not necessarily true. That has cultural roots, and we need to delve beyond that to understand that like a person is worth more than their heart pumping. And all people will die. And that's not necessarily always a bad thing, and it's not a sad thing. It is a beautiful thing. And how do we see people to the end of their beautiful life? And how do we give them peace and honor and beauty and dignity when they need it most? And so I just encourage you to think with that mindset while you read this paper and while you kind of listen to the conversations to be had here. So do you think Dad would have benefited from having a DNR in his situation had he had an advance directive that outlined his wishes explicitly written down somewhere? Because I know that you were aware of his wishes, and I think that most of us were. But from your perspective, how do you think that that would have played out differently?
Well, I was married to him for 18 years, almost 19 years. We were high school sweethearts, so add another 5 years to that. And we talked extensively about his wishes and had he written down or had those things in writing because he remarried and had an absentee wife, I think none of the suffering that he went through would have happened. So, yes, I knew, kind of everyone knew, even you children knew what his wishes were, but all our hands were tied because the one person that could speak for him chose not to show up and advocate or speak for him. So, yes, having things written down would have saved him a lot of suffering.
Yeah, I wholeheartedly agree with that. There's also a degree of, not that this happened to us because all of our hands are tied, but had someone been able to make that decision, like children wise, if it had gone to, his next of kin children wise, and let's say they knew what dad wanted, but it wasn't written down anywhere, there could have been a lot of discord in the family about that. He was very outspoken with what he wanted, though, so I think that we all knew, especially after his brother had died, he made it very clear to all of us.
Yes, he verbally said it over and over and over again, but because his wife did not show up and participate in his health care at the time, there was no one to speak for him because the state falls on the wife when there's no written wishes. So, his mom was there from day one, from onset, but her hands were tied, which I think is crazy because that's his mother. Like,
Yeah.
we never outgrow our mothers, and our mothers know us better than anyone. And she couldn't do anything but watch him suffer.
Do you know if they had called an ethics consult in that hospital?
They did. They did call an ethics board because his wife wasn't showing up. And they did discuss those things. I wasn't part of it, obviously, but
Is
they
that when
did,
APS got involved?
yes.
Okay.
And they took the power out of her hands because he needed medical treatment and his insurance didn't cover it, and they had to go to another system.
Who got to make decisions? Did the state make decisions until he died, or did one of us get it before?
The state made the decisions because his wife was not willing to make the decisions.
Got it.
So he basically became a ward of the state because she wasn't showing up.
Yeah, we see that a lot with the hospital that I work in, just much less so because most of my patient population all knows that they're dying. So they typically have people appointed. So, but I was talking with my other interviewee about ethics because we call it ethics for different reasons. Um, so I just was wondering if he got an ethics consult. I also didn't realize
Well, and
how.
honestly, once the state took control of him, they dumped him in a facility that was not at all helping him.
Oh, I could write you a million papers about state facilities, but
Yeah, they put him in a room and they just never showed up again because the state was now in control, which the control should have gone to next of kin, but it didn't because the state, once his wife opted out, then it's like not having a will, right?
mhm.
The state gets to decide what to do with your kids or your stuff. So